Firstly, I'd like to speak presenting this article wrote for family physicians. There are many differential diagnoses at the origin of all the pains and pathologies of different quadrants of the abdomen or sectors of the abdomen, but we will focus on the right lower quadrant. I mean, we will speak about colonic pathologies, gynecologic pathologies, renal pathologies, and I'd like to present at the end some tricky cases with an ambiguous diagnosis. Firstly, please remember that your tools are useful to evaluate radiologically the normal anatomy. Why we'll speak about a normal anatomy? Because development mistakes are possible. I mean, this is a patient with a situs viscerum ambiguous where we don't know what is in the right lower quadrant. Obviously, they are more frequently detected as anomalies in pediatric age, and this drawing shows that the normal results of the embryological development is the fixation of the peritoneum along this long posterior abdominal line that, in cases of a lesser line, gives more mobility to the structures of the GI tube. And this is a patient, to show you a clinical example, a practical example, who arrived to us to perform a CT colon enema. Look at this strange situation. On the right side, we may find all the small bowel. On the left side of the abdomen, we may find all the large colon. I mean, along this practical line of reflection, we have small bowel right-sided and the colon on the left side. This is a result of an embryological defect. Maker's diverticulum, it may mimic an appendicitis, it may mimic epigastric pain. We found that this Maker's diverticulum evaluating with a CT colon enema the patient, and we were sure of our diagnosis performing a scintigraphy before the intervention. Not so frequently duplications, but more frequently are anomalies of a fixation. Why we will speak about anomalies of fixation? Because they may determine internal hernias and intussusceptions. This is a patient who arrived at our emergency due to a subocclusion condition. You may detect some air liquid levels and a right-sided abdominal pain. The problem was this 5 centimeter solid hypodense mass, which determined an iliocolic right-sided intussusception due to an extra mobility of intestinal structures. The surgeon performed an iliac resection, and he found that this solid mass which determined this intussusception, a gist of the small bowel. Take care to the patient in emergency. They may have embryological development defects. This is a woman. This is a normal plain film made in emergency, but take a look to the upper part of the plain film. We perform CT for other problem in this patient, and look at what we found. The right base, the apex of the heart were right-sided. The liver was on the left side. The spleen was on the right side. In this patient, we may find, obviously, a different anatomy because the cecum is not in the right lower fossa as you wait, but is left-sided, and on the right side, we may find just this long, redundant sigmoid column. For this reason, please take that the anatomy would be normal in your patient before any other choice. We may investigate the right lower quadrant pain just using all our armamentarium. We will speak about MR imaging, why and when more particularly. The literature has no confidence in the emergency conventional plain film radiology, because in these 3 series, with many patients observed, the pathological findings were detected only in 10%, 38%, 20% of the patient, just in a very small number of patients. Such a poor diagnosis from a conventional playfilm in emergency, in effect, a perfect quality would be required in any case, and this is very difficult due to limits of the position, of the patient status, and of the clinical settings. Stuart Mirvis in 80s wrote that in emergency, conventional radiology must be reduced to plain film only orthogonal, one each other, because we have to do more cost-effective, more dose-effective. The suggestion is you may perform CT. Look at this conventional, not enhanced, very easy CT examination in this patient. Such informations you may have about this right-sided inguinoscrotal hernia with the situation of occlusion determinate above. Why we prefer tomographic imaging? Because it increases our sensitivity and specificity. Multi-detector CT is following the literature all around the world, the first imaging in case of emergency as a first approach. I mean, when you don't have any diagnosis. MRI, radiation-free, even fantastic imaging, but not so useful in emergency. What about appendicitis? Normal, conventional semiotics, well known. The pathological appendicitis is thickened, more than 6 millimeters at ultrasound, more than 10 on CT, very easy. In case of enhanced CT, you may detect an hyperenhancing of the appendix, or you may find inside a stercolite. The rearrangement of the wall, the modifications, the pathologic modification, determine an increased pain just during the compression performed by the sonographer. Please remember that we are clinical radiologists. For this reason, we are performing imaging, but we may, to improve our diagnosis, we may use clinical tools as Alvarado scores, some clinical scores to improve our information about the pathologic situation. The blood sample tests are useful to improve, for instance, an US evaluation, an ultrasonography evaluation, to be sure of an appendicitis. The normal appendix, very easy to detect. This is a contrast enhanced CT, particularly a CT colon enema examination. The normal appendix is not dilated, the fatty around is normal, there are no nodes, no free liquid, and it's very easy to recognize. The appendix may have different shapes and length. And this is an amazing article wrote by Perry Picard in his huge number of CTC's examination. You underlined that the appendicitis is more frequently if an appendix has a length between 4 and 10 centimeters. Less frequent, less than 4, less frequent if the length is more than 10 centimeters. The American College of Radiology define about appendicitis in adults and in adolescent population, obviously. More sensitivity and specificity for CT. Sonography is very important, but operator dependent. We have to remember that maybe even in case of irradiating technique, the rating is very high for not enhanced and contrast enhanced CT. Good for sonography, but not so high as well as CT. From an evidence in the literature point of view, please remember that the SAR defines that the negative appendectomy rate lowers in case of preoperative imaging. If you perform preoperative imaging, sonography or better CT, you may reduce the number of negative appendectomy from 22 to 11%. The conventional sonography findings are well known. In axial, this is the last iliac loop near the pathological appendix. We know that the aspect of target sign is typical, that the pathologic appendix is not compressible and blind-ending tubular structure, and we may find inside an appendicolite extra sign to be sure of our diagnosis, extraluminal air or extra appendicular fecalith are found. Obviously, the changes of the fat around the appendix is very important. From a CT technique, we may perform not enhanced CT, or we may have a good sensitivity and specificity if we use contrast medium, per os, or intravenous contrast medium, we have best results. But don't be afraid. If your patient is allergic, you may perform not enhanced CT, and you may obtain a very strong accuracy with your examination. First clinical case. This is a 54-year-old man in emergency, right lower quadrant pain with acute signs. You may detect in this not enhanced CT the fatty changes around the cecum. This is the small abscess around the appendix, which involves some small bowel loops. In the coronal, we understand that the pain is irradiated to the right thigh just because the fat involved in this inflamed situation is involved in this right inguinoscrotal hernia from this abscess from the appendix. CT and sonography are useful to depict alternative diagnosis, complications, abscesses as an example, or to manage a practical access to drain or to treat the abscess. I'd like to change the subject, and I'd like to change the pathological problem. We have a young man, suboccluded, right inferior lower pain and acute signs. We performed a contrast enhanced CT. Please look at the changes of the fatty tissue around these right-sided small bowel loops with inside ileal stools, the fatty tissue, the haziness of the fatty tissue, and the involvement of the sigmoid colon with these ileal loops, and some small bubbles of free air outside the intestine. This was, in reality, maybe if the pain was on the right side, a sigmoid colon diverticulitis. And in effect, we may confirm in the coronal image the aspect of the small bowel loops and the involvement of the fatty tissue around the sigmoid colon and this inflamed small diverticula. 4 days or 5 days later, the situation got worse. Why? We performed a not enhanced CT in this young man, and we found free air in the abdomen, a perforation of a diverticula. We found a small dot of air in the fatty tissue around the intestine, occlusion, ileal stools sign, liquid along the paracolic right gutter, lymph nodes here, and this man was operated of a sigmoid resection. Alternative tool for diagnosis. We have to speak only about MR imaging. Good sensitivity and good specificity, but today is under consideration to be used in these particular situations. Please consider that the right lower quadrant pain is the cause of admission in emergency at a second place only after the thoracic pain in a population older than 15 years. For this reason, it is a very important cause of admission in emergency. The appendicitis is the first reason of, but we may have infectious condition of the intestine, right colon diverticulitis, pathologic conditions of omentum and mesentery, and the pain of renal origin. Just to speak about urolithiasis, very easy image, coronal plane. This is a contrast enhanced CT of the same patient. Why we perform CT for urolithiasis? In adult population, as the literature underline, is very modest, very low the dose at low dose or ultra low dose technique, and this is an article of 2007. The dose is so reduced that please perform in adult population CT to be sure of your diagnosis. How we may evaluate the intestine? Very frequently involving pathologies of the right iliac fossa and in the right lower quadrant. The problem is that sonography is useful, but not so essential to clinical diagnosis. Some intestinal distension is required. How we may dilate the right colon and the last tract of the small bowel? In 60s, Roscoe Miller solved the question with a large amount of barium sulfate. Retrogradely, he dilated the colon and the small bowel, but it's not so easy to perform this technique. We agree with these authors that speaking about a pathology of typical pathology of the right lower quadrant, they underline, speaking about MR, that at today enteroclysis and enterography has a very comparable efficacy from a clinical point of view. For this reason, we moved from the enteroclysis to the enterography, but we introduce a new technique of examination that I will discuss with you. When we clean the intestine, we are cleansing the small bowel and the large bowel. For this reason, we may theoretically dilate the large bowel, peros, and we may dilate retrogradally the colon using water. In this way, after a cleansing and the intestinal preparation, you may have the small bowel dilated and the large bowel dilated to evaluate all the GI tube. And in this article, we compare 4 different techniques, CT enterography, CT enteroclysis, and we observe, please look at the purple column, that CT enterography and water enema may dilate from the jejunum to the rectum in a very acceptable manner all the GI tube. What about the last iliac loop hyperemia? This is a diagnosis that all of us we may meet every day at our hospital performing CT. And I'd like to share with you 3 cases. This is a CT colon enema. You may detect that the last iliac loop is thickened, multilayered, and hyperemic. The diagnosis is easy. Crohn's disease. In this second situation, look at this. We have hyperemia, but we have not multilayered aspect, not thickening. More difficult, not oncologic, probably infectious origin. In effect, it was an ileitis. But what about this third guy who arrived in emergency, right-sided pain? He was previously appendectomized. Leukocytosis. What about his last iliac loop? We may detect a last iliac loop thickened, not multilayered, and hyperemic. The diagnosis is more challenging. We suggested a lymphoma, and it was a lymphoma in this young man. We change pathology and we change patient. An elderly patient, 70-year-old, episode of enterorrhagia. He arrived anemized in emergency. No acute signs, right lower quadrant pain. We perform a double distension of the small and of the colon, of the small bowel and of the colon. Please look at the distension of the iliac, the colon loops, and look at this small, solid, hyperenhancing mass in the last iliac loop. We may detect this small mass, and our gastroenterologist decided to perform a video capsule. But the diagnosis by video capsule was so difficult because he found only this pink bulging of the mucosa toward the lumen, not more, because probably the pathology was under the mucosa, and in effect the diagnosis was made by the surgeon who found a gist of the small bowel. Normally, if we are in face of a typical pathology, and if we perform a good examination from a technical point of view, the diagnosis is not so complicated in my opinion, because we may detect the skip lesion, the thickened aspect of the last iliac loop, the hyperemia of the mesenterium, last iliac loop involved, some nodes, and the com sign. All is easy and understandable. Problem are complications, as the abscess. An abscess may find easily by CT. In coronal reconstruction, we have another case of Crohn's disease, ilioileal fistula, and this well-detectable abscess. Sonography is limited due to the lesion site. MR is less frequently used because not used in emergency, Multi-detector CT, once again, is our choice. Good sensitivity and good specificity. But what about the X-ray dose given to the patient? If we have in the adult world, you will be surprised if you may know that this image with the distension of the small bowel, of the large bowel, of the colon, is obtained using 60% less dose than a conventional multi-detector CT of the abdomen. Just using today iterative reconstruction algorithms as VIO or ASI in GE, we may speak about Siemens or other company, you may obtain very good images with a strong reduction of the CT dose. Just a few miscellany to speak about not so frequent but misconsidered pathology of urologic origin. Two men with urinary symptoms, intermittent hematuria, urinary incontinence, inguinal swelling. This is the reason of the inguinal right swelling of the first patient, a bladder hernia, or both hernias on both sides. This is a spermatic cord. This is an important pathology due to the fact that sometimes is lately diagnosed. Why? Because these inguinoscrotal bladder hernias, if we don't know the literature, and this is a very interesting article that I suggest you, are postoperatively diagnosed in 60% of cases with a huge risk for the bladder, perioperative risk. And we have to consider that the conventional urography is not more performed. Sonography, so-so for this diagnosis. CT is, even in this case, a good method to find these pathological findings. What about gynecological causes of right iliac fossa pain? This is a woman, yet operated for ovarian endometriosis. She arrived with right lower quadrant pain, performing a sonography. I found the liver, the right kidney, and this very strange pear-shaped intruder. He has some Doppler spot, venous or arterius. This is the T2 weighted image in MR sequence, white. This is hypo-intense, no blood in T1 weighted image, no signal in diffusion weighted image. Look at the T2 coronal, very strange shaped structure, and look at the colon CT enema in this woman. We dilated the colon, and you may detect the pear-shaped structure here, right-sided flank. We were not able to perform the diagnosis. We wait for the surgeon, and the surgeon told us it was an appendiceal mucocele. I suggest you this very interesting article of AGR, where you may find some images like our case, with the pathological specimen with some areas of adenocarcinomatosis degeneration. Second case of a woman operated for endometriosis, relapse of intestinal disease is suspected. She has right flank pain and pelvic redundant pain. She arrived to perform a colon enema, and we perform the distension of the colon, of the small bowel, and we detect this small hyperenhancing solid nodule on the last ileal loop. The diagnosis was ileal endometriosis. Third and last case of a woman yet operated for conventional ovarian endometriosis. She arrived complaining of abdominal bloating, fever, CA 125 increased, and right iliac fossa pain. She underwent double contrast barium enema. We were involved as a second opinionaire, and you may observe the long colon, very typical in a female affected by endometriosis, but the problem was the defect of filling of the cecum. We performed a colon CT enema. We detected a solid mass in the cecum, but take care. The last ileal loop is normal. The right colon wall is normal. No nodes. no free liquid. For this reason, we thought to a benign pathology. We suspected a relapse of cecal endometriosis, and we were right, because it was an endometriosis of the cecum. Gynecological causes of right lower quadrant pain without oncologic origin. Please remember that huge myomas may determine abdominal swelling and abdominal pain in women. Gynecological causes sometimes of oncologic origin, sadly. This is a very difficult case of a woman that she arrived in emergency, and I was on duty, and I remember she suffered of rheumatoid arthritis. Briefly, she was in therapy, and her family physician suspected of something as of appendicular origin. She performed a CT colon enema negative. In emergency, we have had a suspected situation of appendicitis. I performed a not enhanced CT, and immediately after a contrast enhanced CT. Due to this fact, you may see the haziness of the fatty tissue around the intestinal loops, but main of all, you may observe the left ovary lesion and the free abdominal liquid. This is the coronal reconstruction. 2 days after, this woman underwent a PET-CT examination, and this is the MIP image, where you may immediately detect the positive fixation of the FDG around the colon. This is the hybrid image with the fixation of the FDG due to this peritoneal carcinomatosis due to left ovarian adenocarcinoma. Sometimes ovarian cyst may be of huge dimension, as in this case, or smallest, but with a solid component, doubtful, with some enhancement at CT for these problems. The aspect, if the pattern is so doubtful, but we have to remember that ovarian lesions may have benign, borderline, or malignant origin. And I underline to your attention this article, very interesting, because speaking about sonographically detect ovarian cyst, the authors underlined that it is important to be sure of to remember the age of the patient, because in premenopausal patients there are some distinction of simple and complex cyst following certain dimension and certain criteria. Different criteria in case of a postmenopausal age. For this reason, please read the article, because it's very interesting to better understand the sonographic approach to ovarian cyst. Cystic-like masses without a strictly ovarian origin. This is a T2-weighted, fat-saturated sequence of a woman. This is the pubis, this is the bladder. You may detect some ovarian cyst left-sided. On the right side, you may observe this tubular structure, sausage-like structure, dilated, you may see here. This is an hydrosalpinx. On the other side, in this T2-weighted axial image, you may find once again cysts on the left side. On the right side, it is tubular, dilated, hypointense structure due to probably the proteinaceous or the mucus contents, once again an hydrosalpinx. And to read something about, I suggest you this very interesting comprehensive review of radiographics about MR and hydrosalpinx. What about the multimodality imaging workup for ovarian pathology? To sum up, sonography has pros and cons, but we have to remember that if we may use Doppler, Doppler is not specific. What about CT? Very important in pre-treatment planning, but is an imaging of low sensitivity. If we use MR, it's the first imaging to distinguish malignant from benign lesions. And last not least, PET-CT with advantages and disadvantages. Particularly, I remember you false positive and the false negative of PET-CT in pelvic imaging. For this reason, useful to couple PET-CT in oncologic patient with MRI in all cases. Pelvic lesion may have no gynecological origin. This is an elderly woman with a positive finding at deep palpation right-sided. She arrived anemized. We performed a CT colonography. In prone position, no contrast enhancement. In supine position, we moved to the contrast enhanced colonoscopy because we found it is a solid mass protruding on the right side of the colon. This is a contrast enhanced colonoscopy. In reality, this examination was a part of a PET contrast enhanced colonoscopy where we observed, where we characterized it is a solid mass right-sided in the right part of the colon here. The hybrid image just described these positive findings. And we thought to the problem of PET-CT as one-stop shop imaging in colon cancer. Is it useful? Following this article, wrote by specialists from the economic world and from the medical world that compared PET-CT, conventional CT, normal CT, and MRI in imaging of the colon cancer, the PET-CT is not a useful choice as a one-stop shop in case of a first diagnosis, but it becomes a very useful tool in case of recurrence of colon or rectal cancer or in case of a diffused disease. And to conclude, I'd like to show you 3 very tricky cases arrived at our emergency. The first is a man. He arrived with the diagnosis of family physician of appendicitis. The diagnosis was, we are sure that this is an appendicitis. In reality, if we look at the right colon, we observe feces here and ileal stools here and other feces inside the last part of the small bowel. This was a situation of retrograde backwash in the last ileal loop, well known in the radiologies of 70s, frequently mimicking a situation of the appendicitis, but it is not an appendicitis. Second case, a woman, she arrived with a sonography, hydronephrosis, right-sided hydronephrosis. Okay, we confirmed by CT, but we performed a contrast-enhanced CT, and we found that these small masses, right-sided, near the right ovary. The problem was solved with the stenting, but the lesion was still there. We were doubtful. We were not able to complete our diagnosis. We wait for the surgeon. And the surgeon, please take care to this pathology, found a retroperitoneal sarcoma. This is a very uncommon findings, but very able to realize some problems like hydronephrosis, or it was a oncologic main importance problem. Third case, this is a man who arrived with anemization and right-sided abdominal pain. We performed colon distension and the small bowel distension, and look at what we found. This small solid, tiny nodular lesion here, hyperenhancing in the last ileal loop. We immediately found, with the experience of before, to a GIST. In reality, the diagnosis, the surgical diagnosis, was of an intestinal net tumor of the ileum, and this is the third article that I suggest you to read. To sum up, we were asked to analyze clinical cases, understand the imaging features in acute conditions, understanding the use of mixed technique, comparing radiology, endoscopy, and nuclear medicine. At the end, to know basic principle of pre- and post-therapy imaging. I may say only, I hope we did it, because it's not so easy, and I'd like to thank you